Let's start. Last class we just finished heart failure. For heart failure, what was the principle? How we treat heart failure? Must reduce preload and reduce afterload. How many groups we use for heart failure? Angiotensin converting enzyme inhibitor 1, angiotensin receptor blockers 2, diuretics 3, number 4, vasodilators, number 5, beta blockers. At last, number 6, inotropics. To start from angiotensin converting enzyme inhibitor, angiotensin receptor blockers, then we go for diuretics, then we go for vasodilators. And the important point of beta blockers, about the beta blocker, that keep in mind, if the heart failure is very severe. In severe heart failure, at that time, we must avoid beta blocker. Okay? It's an important point. Keep in mind that beta blocker you can give for heart failure, but for mild case, if the heart fail in the starting condition. But if heart is already much failed, that's why I'm right at this drug at last number. I'm not going to start from beta blocker for heart failure therapy. Okay, so beta blocker at last. First preference, RAS blockers, angiotensin converting enzyme inhibitor, angiotensin receptor blockers, and then go for diuretics, go for vasodilators, then go for beta blocker. The beta blocker, if heart is very severely, it's not performing its duty, so we must avoid beta blockers. Understand? The beta blockers can cause cardiac arrest if heart is already very weak. Okay, cardiac arrest. This thing keep in mind. Another thing, the calcium channel blocker. Calcium channel blocker contraindicated in heart failure. You can see I am not writing here anywhere calcium channel blocker. Yeah. So calcium channel blocker are contraindicated in heart failure. Understand? Calcium channel blocker are contraindicated in heart failure. At what time we need to use inotrop? I explain everything. What time? You have the option for inotropes. The first, we reduce the preload and afterload. Everything done for heart. Heart is under process of failing. Heart is not improving. Yeah. Our last hope was inotrope digoxin. Inotrope digoxin. Clear? And another inotrope, Millery non. Millery non. Another Emery non. Another Dabutamine. So these inotropes. They're doing what? They support the heart for contraction. They give power to very weak heart. I only give example if the person is getting elder and elder and elder. Can lift very heavy weight? No. First you reduce the weight. First we must reduce the weight because elder person not able to lift 50 kg, just can lift 10 or 20 kg. Yeah. So first, if the elder person not able to perform its duty, now it's working in factory, elder person. Failing heart is same like a elder person. Understand? Healthy heart is a young person, can lift the full load, after load, preload, can bear every type of any type of load. But failing heart, if heart is already fail, that failing heart is like a elder person. Easily can understand this concept. Clear? So if you want elder person, like for example, elder person doing the duty, doing the work in a factory, in doing some like taking goods here and there like this, yeah. So now if you want your elder person must still working there, must still working there. So what you do? You reduce the load. Understand? Reduce the load. Then that elder person still can lift the weight. Before elder person just lift the 20 kg, now reduce the load to 10 kg. Understand? If that elder person still not able to perform its duty, then at last what you do? At last, only hope, give power. Understand? Give external power in the form of calcium. It's the only hope. Otherwise, that elder person not able to perform its duty completely die. It's a similar thing like heart failure. Understand? At last we go for power, power supply. That's your power is your inotrope. Inotrope increase calcium inside and help the heart for strong contraction because heart is already too much failure. Clear? This everything about heart failure. Now we move on. Next topic. Next topic is your ischemic heart disease. In ischemic heart disease, we have angina. Ischemic heart disease, we have myocardial infarction. Myocardial infarction. The angina further categorized unstable, un, unstable, this side heavy, stable, this side variant, variant. Okay, variant also known as Prince metal. Unstable known as crescendo angina. They are different name. Okay, crescendo. Another name, pre-infarction, just before infarction. Pre-infarction. It's not infarction. Okay. So what is MI? Myocardial infarction, two types. With ST elevation, ST elevation MI. ST elevation MI. Understand? Non-ST elevation MI. Non-N ST. STEMI, non-STEMI. NSTEMI. It means the MI without ST elevation. It means the ST depression there. It is all about ischemic heart disease. Okay, ischemic heart disease. What's the risk factor for ischemic heart disease? But the main thing here, coronary artery. The coronary artery disease due to atherosclerosis. Coronary artery disease due to atherosclerosis. And atherosclerosis in your body, you have very high level of LDL. You are a diabetic person. You have hypertension. You are a smoker. So all these causes lead to atherosclerosis. Atherosclerosis lead to coronary artery disease. So when the coronary artery disease, what happened here? The 70% artery block. If 70% artery block, you have stable angina. If the 90% artery block, you have unstable angina. Understand? So stable angina and unstable angina, stable angina and unstable angina. How about the MI? 100% artery block, 100% block, no blood supply, complete no blood supply. Done? In the stable angina and unstable angina, pain here, the person having pain for 5 minutes or just 5 minutes, and this pain is relieved by rest. Pain relieved by rest. Another thing we put under the tongue, nitroglycerin. Nitroglycerin. If the unstable angina, that pain now going for 10 to 15 minutes. Clear? And this pain not relieved by rest. Rest help you? No. Nitroglycerin put under tongue help you? No. So for these cases, you have MI, STEMI, non-STEMI, pre-infarction or unstable angina. We need here, we need to rush to hospital. Understand? We need to rush to hospital. Clear or not? So here we need the sport, many therapy there. Clear? So stable angina due to atherosclerosis, unstable angina due to atherosclerosis, and MI due to atherosclerosis. Understand? So everything due to atherosclerosis. How about this Prinzmetal angina? Prinzmetal angina. The Prinzmetal angina, what happened here? In this, vasospasm. 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 Clear? For example, any person having the morning time heart attack, morning time, listen here carefully, morning time chest pain is most probable cause Prinzmetal. Patient was laying on bed and having start chest pain and listen bad or good news about financial problem, about family issue, any here we having emotional stress. What here? Emotional. Any emotional stress. What happened? Vasospasm. In emotional stress, what happened? Vasospasm. So vasospasm is not a permanent block. Yeah, vasospasm is just a transient block. It's not. Must keep in mind here. It's not atherosclerosis. So, so what a therapy here? Therapy for variant angina different from stable and unstable. Understand? Therapy for variant angina different from stable and unstable. So what the difference here? For variant angina, we just need vasodilation. You can see here what happened here. SPAS, vasoconstriction, vasodilation, vaso, vasodilation. So here we need here for Prinzmetal variant angina vasodilation. Clear? So which drug we use here? Calcium channel blocker. It's a drug of must keep in mind here. Drug of choice for Prince metal or variant angina is a calcium channel blocker. The calcium channel blocker. The calcium channel blocker doing here what they're doing? Calcium channel blocker, they open the vessel. Yeah, okay. They open the vessel, they dilate the vessel. What's the problem here? Any drug abuser having Prince metal variant angina, one cause I already tell you, emotional stress. Yeah, sad or any bad news here. Yeah. So any drug abuser, let me know about drug abuser. Which drug abuser have an angina attack?
Prince metal
I give you
angina.
Prince metal angina caused by which drug? Drug of abuse. I just give you hint. Number one,
Cocaine.
morphine. Number two, codeine. Number three, cocaine. Number four, alcohol. Which one having
Cocaine.
cocaine? Why cocaine? Cocaine is a sympathetic agonist and causing very strong vasospasm. Cocaine abuser. Cocaine abuser. Okay, one thing. Another drug right here, triptan, also cause vasospasm. Okay, fungal derivative. This drug we use for migraine. Okay, triptan, sumatriptan, ramitriptan, triptan. Later we learn in painkiller topic. Okay, triptan fungal derivative. They also causing vasospasm. Triptan user and cocaine, the drug abuser here, cocaine. They having Prince metal angina. So we need here the calcium channel blocker. For ischemic heart disease, the first I am putting here drug here, the simple drug for ischemic heart disease. We have option beta blockers. Number one, we another option calcium channel blocker. Another option nitrate. The three best drug for ischemic heart disease. Okay, the best drug for the ischemic heart disease. We can add on therapy. The other drugs, the other drug, and the other drug. We can add on therapy according to situation. So what type of angina there and what type of MI there. Clear? So beta blocker, calcium channel blocker, and nitrate. These drugs for ischemic heart disease must keep in mind. Okay, these drugs for ischemic heart disease. If you see any sign of, for example, the patient have a heart attack, yeah, and now you can use calcium channel blocker, you can use beta blocker, you can use nitrates, yeah. So if you observe any sign of heart failure, what are the signs of heart failure? Patient have the pulmonary edema, if left heart failure. Patient have full body edema. Patient have JVP distension. Patient have facial edema. Patient have pedipedal edema. Patient have ascites is a sign for right side heart failure. So if you observe any sign of heart failure, then you must avoid calcium channel blocker. Understand? Otherwise, you can use these are the very good drug for ischemic heart disease, calcium channel blocker. Understand? Okay, now again come back. Drug of choice for variant angina, Prince metal angina. Variant angina, Prince metal angina. Which one? Drug of choice, calcium channel blocker. Let I explain the group and what are the group of calcium channel blockers. Okay, next come to stable angina. Stable angina, we just need here nitrate plus rest. Which nitrate? Nitroglycerin. Nitroglycerin. Clear? Nitroglycerin. And when this patient come to you also, of course, the patient have chest pain, you visit the doctor. Yeah, the patient have chest pain, a doctor. Patient undergo ECG. Patient we perform investigation. ECG. Oh, you have stable angina. It's okay. It's no problem. But next time be careful. So what you advise to patient? So what are this stable angina also caused by what? Stable angina caused by atherosclerosis. Stable angina caused by atherosclerosis. Atherosclerosis due to diabetes. Atherosclerosis due to smoking. Atherosclerosis due to hypertension. So what you advise to patient? Atherosclerosis due to LDL. Now control your sugar, control your hypertension, quit smoking, and stop stop consumption of fatty meal. Understand? You give this advice. Another thing, how you can control, give antihypertensive. How you can control diabetes, give anti-diabetic. So these drugs we add on. This is add-on therapy. Understand? You add, for example, if patient not know before having diabetes, now have suddenly having chest pain. If patient already familiar with diabetes, the patient already on therapy for diabetes. Otherwise, you must start therapy for diabetes. You start therapy for hypertension, and you must very important test here. Must investigate LDL and HDL level. If patient have LDL very high, start another drugs. Start drugs for lipid also. Understand? Start drugs for lipid also. So this is the precaution. We must prevent this stable angina change to unstable angina. It may be lethal. Clear? In the first, the initial, we just give nitrate and nitrate with nitrate, nitroglycerin, nitroglycerin. If the patient is hypertensive also, you must add beta blocker to therapy. You must add calcium channel blocker to the therapy. Understand? If the patient also hypertensive. If patient also hypertensive, you add calcium channel blocker, you add beta blocker. Nitrate, we already giving nitrate. Yeah? Okay, now come to unstable angina. What's unstable angina? Pain is long lasting, 10 to 15 minute resting. Rest, not relief. Nitroglycerin, pain not relief, still there. You know what we do now? What you do now? Give nitrate. Give nitrate, give beta blocker, give calcium channel blocker, give morphine. Oh, why you give morphine here? You want to stop pain. If you not give morphine, the pain still there. Pain can make more worse this unstable angina. Clear? Because in unstable angina, you already know 95% artery block. If the patient have the pain 10 to 15 minute chest pain, yeah, 10 to 15 already 90 here. Just 70% block. 70% block. We still have chance to block this progression. Yeah, we still have chance to control hypertension. We still have chance to control diabetes. We still have chance to quit smoking. We still have chance to control LDL. But what do you think about here? What happened in unstable angina? Unstable angina already game over. Already 95%. 95% already artery is blocked. Okay. Thank God patient not died. Nitrate, beta blocker, calcium channel blocker, morphine. And what drug you add here? More drug. You add drug for LDL. You add drug for hypertension. Understand? You add drug for hypertension. All these drugs I give to unstable angina patient. Clear? Nitrate, beta blocker, calcium channel blocker, morphine, opioid to control pain, LDL, and hypertension to control hypertension. We also use drug to control diabetes also. So all the drug patient must take all these drugs because next time what happened already all the 95% block here. So if this plaque rupture, sudden MI. Understand? Sudden MI. Now in MI there are two categories, STEMI, non-STEMI. STEMI and non-STEMI. What we need to do here, what happened in MI? In MI case, one thing must keep in mind, unstable angina and MI, they both the patient. So what are the I write here? Unstable angina and MI, they both are quite similar. What the similarity there? The pain duration 10 to 15 minutes. Here pain duration still 10 to 15 minutes, sometimes exceeds 30 minutes. Okay. The pain is also severe, very severe pain, very severe pain. Understand? Very severe pain, very severe pain. Pain can relieve by rest? No. Pain can relieve by rest? No. Pain can relieve by nitroglycerin? No. Pain can relieve by nitroglycerin? No. By clinical feature, the patient just similar to MI, understand? But the therapy is totally different. Unstable angina and you perform the ECG. What happened here? You perform the ECG in unstable angina, ST depression there, but in MI, two possibility. This segment may be depressed, and this segment, ST segment, may be elevated. I don't know it's unstable angina or MI, because you can see here, maybe depression, maybe elevation, but here just depression. Clear? You perform the ECG, maybe this MI or it's another type. It's a non-STEMI. This MI is a non-STEMI. Yeah. So if the patient comes to you with unstable angina or MI, you want to differentiate, you must send the one lab test to check the CKMB, to check the troponin. Understand? Trop T and trop I. This investigation for MI. Yeah. So if the test was positive, it's mean it was MI. If this thing not present in blood, it's mean unstable angina. You just can differentiate from here. What's the difference here? In what's the definition of angina? What's the definition of angina? Angina
Pain, sir.
means angina just ischemia. Okay, angina just lead to pain. In angina, I'm describing their pathophysiology of angina. Okay, angina just ischemia. Understand? When ischemia plus death of cell, when ischemia lead to necrosis, that is known as infarction. This you know about infarction, yeah? Myocardial infarction. Ischemia lead to death of cell. Here cell in angina, cell still reversible injury. If you open the artery, if you give the drugs, better drugs, the patient can be reversed. Myocardium not damaged. If cell is not die, can enzyme come out? Can protein come out from cell? Of course not. In unstable angina, in lab test, no CKMB, no troponin. Why? Because in angina, no cell death. In angina, no cell death. Understand? No cell death. Cell in injury stage, but cell are injured. That cell is your reversibly injured. Membrane swell, intracellular some changes there, but cell not die. Cell not necrose. Clear? If cell die, is your MI. When cell die, membrane rupture, everything come out. When everything come out, it's mean here we having enzyme positive. The enzyme CKMB come out here. Yeah. But here all the enzyme are troponin still negative. From here you can know it's unstable angina or MI. Understand? Go for lab. Go for lab. Clear? If STEMI, or it's a dangerous one, non-STEMI. Listen here from ECG. This one, ECG, ST segment elevated, okay, and this side ST segment depressed below the line. It's a depressed, here ST segment elevated. What happened inside the unstable angina? ECG of unstable angina, still ST segment depression, still below the line. Now tell me which thing is much similar to unstable angina, STEMI or non-STEMI? From ECG, all features were same. Two things are similar here. Unstable angina quite similar to non-STEMI. Understand? Unstable angina is very similar to, listen here. How about the pain duration? 15 to 30 minutes. I'm exceeding the pain. How about the severity of the pain? Very severe. Yeah? Very severe pain. Pain relieved by rest? No. Pain relieved by nitroglycerin? No. In ECG, ST segment, depressed. Yeah? From these features, what you say to this? Is your stable angina? Of course, it's not positive stable angina. Yeah? Understand? It's not possible stable angina. Is your maybe unstable angina? Maybe non-STEMI. Understand? It may be unstable angina, maybe non-standing. Unstable angina, non-standing. So from clinical feature, both things you see here, the pain, severity, rest, nitroglycerin, these things, they just give me hint. It may be unstable angina, patient may be not standing. You perform the ECG. What happened in ECG? In ECG, ST depression. Also here the ST segment depressed below the line. Yeah. Here again ST segment depressed below the line. So from ECG you still not able to diagnose. What you need here? You need help of lab. Understand? In angina, in unstable angina, any necrosis? No. Here necrosis start. Understand? Here is an infarction. So enzyme CKMB and troponin. This enzyme will foster. Okay, this enzyme will foster. How about here CKMB and trop? This enzyme will negative. Understand how you differentiate unstable angina from STEMI? So why you need differentiation here? Because the treatment plan totally different for MI and totally different for unstable angina. For unstable angina, I just have the main key drugs here. So what's the principle? For example, what happened in ischemic heart disease? In ischemic heart disease, oxygen supply less, oxygen supply, oxygen supply less. What to think about the demand? Demand of the oxygen is very high. Demand is high and supply is less. Understand? So what will be your principle? How you can treat this? You must increase the supply, increase the oxygen supply, yeah, and decrease the demand. You decrease the demand, yeah, decrease demand and increase supply. In ischemic heart disease, one thing demand, another thing supply. There are two things here, yeah. Supply is your blood supply. One thing supply, one thing demand. The mismatch, maybe demand very high, hypertrophy there, maybe supply very low, atherosclerosis lead to blocking of artery. Yeah, understand? Supply less, demand more. So what you need here, you must make it again equal. Decrease the demand. How you can decrease the demand? Decrease demand by using beta blocker. Beta blocker doing what? Beta blocker is a gold standard here for this patient. Yeah, it's a very good drug. Beta blocker decrease the heart rate. So if heart rate now decrease, so what happened? The muscle contraction decrease, oxygen demand decrease, energy requirement decrease, everything decrease. Understand? So how about the nitrate? Nitrate doing what? Nitrate dilate every vessel. Nitrate dilate every vessel. Clear? Nitrate dilate every vessel. They also increase the supply. They also decrease the demand. Very effective. Understand? So nitrate also key drug here. Calcium also dilate the vessel. Understand? So it's our principle here. So main three drugs here working. Number one, beta blocker. Number two, calcium channel blocker. Number three, nitrate. What you give extra? It depends upon what is the situation here. Clear? For any type of angina, you must just give this is okay. If the patient having obesity, patient have diabetes, patient have hypertension, patient have very high level of LDL, so you also use drug. Add these drugs. Okay, add drugs for hypertension, add drugs for diabetes, add drugs for LDL. Clear? Basic three requirement here: beta blocker, calcium blocker, and calcium channel blocker and nitrates. Understand? It's a main thing for ischemic heart disease. These drugs are basic requirement for ischemic heart disease. The other drugs for diabetes, drugs for hypertension, drugs for LDL. So it's according to situation. They say what type of angina there. Real? And when patient have history of diabetes or not, patient have history of hypertension or not, patient have history of related with the obesity or high cholesterol level. If the patient have all these things, then we add because the most common cause related with atherosclerosis, you must have a high level of cholesterol, you must hypertensive, you may be diabetic, you are smoker. So all these are the main four risk factor for atherosclerosis. Clear? For unstable angina, we must perform this. Control diabetes, control hypertension, control cholesterol. Okay. So, but if the what is the difference of angina and MI? What therapy different? We just need another group here. Another group. If the patient, for example, the patient having MI. Okay. I just now describe the patient have MI or angina. How we differentiate? Go for lab. Clinical feature not tell you it's a MI or angina. Understand? Clinical feature not just tell you it's a MI or angina. You need the lab help. So it may be MI. Which MI is similar to unstable angina? Non-STEMI. Okay. Which MI very similar to angina? Non-STEMI. Understand? Which MI similar to angina? Non-STEMI. For the therapy for both, totally different. For MI patient, we need to add anticoagulant. This is an important requirement. Understand? We need to add anticoagulant like heparin, like warfarin, like antiplatelet. These drugs I must add to MI patient. Clear or not? The other things are same: beta blocker, calcium blocker, nitrates. Drug to control diabetes, same. Drug to control hypertension, same. Drug to control cholesterol, same. But the main thing I add here, anticoagulants. I need anti-clotting drug. I need drugs to break the clot. Yeah? I need drugs to break the clot. So that's an anticoagulant here. This anticoagulant I am not using in unstable angina. Unstable angina, calcium channel blocker, beta blocker, and nitrates. Okay. The other drugs to control diabetes, to control hypertension, to control cholesterol. The other drugs are same. Clear? But for MI patient, I must give anticoagulant. This done or not? There's a key difference here between MI and angina. Okay, you can see the big therapy difference also. Okay, now come here again. Unstable angina. What you give? Beta blocker. Okay, calcium channel